Welcome to the Becoming Superhuman podcast. I'm your host, Trevor Schmidt. I was trained in Western medicine as a physician assistant, where I was exposed to the dark side of medicine. Through self-education and biohacking, I figured out ways to hack my system, becoming a better version of myself. We'll explore the wisdom and insight of my findings with each episode of the Becoming Superhuman podcast. All right, hello and welcome to the Becoming Superhuman podcast. We have a special guest here, Augie Galindo, who's a physician assistant for 18 years now, and he started his journey in EMT training. And since he's started his own business as in testosterone replacement in 2012, and now has 5 clinics. It's amazing, Augie. I'm sure you have some valuable information. So how are you doing today?
Doing great. How about yourself?
Fantastic.
Good.
So tell me a little bit about how you got into this. I know you started in emergency medicine and then you shifted over to hormone replacement. So what was the path like for that?
A lot of jumping from stone to stone, but I started as a fireman paramedic. I really only became a paramedic so I could get hired as a fireman.
Yeah.
Quickly got immersed in the EMS world because you do a lot more of that than you do firefighting. So medicine became my kind of front and center. Started doing extra things outside of the scope of EMS. So working in the hospital, then I did flight transport for a couple of years on the fixed and rotor. And that's really what kind of set my pathway into something outside of the fire department, something where I could do more than what the limitations of even being a flight medic allowed. So went to PA school, long process through that, but very unconventional route. I have 3 now very useless associate's degrees and no bachelor's, but I have a master's degree. So roundabout academic pathway. And then went straight into emergency medicine. It's kind of the natural evolution from EMS. And from there, did a couple years in internal medicine. And when that job ended unexpectedly because of some Medicare malfeasance on my owner or the practice owner's part, ended up dropping into low T care. And that was something that's brand new to me, kind of had to learn it on the run. And actually only worked for that practice for about 7 months before handing in my resignation and already making plans with my now business partners, then colleagues, to start our own. So started, I guess, would have been March of 2012 for somebody else. And then we were launching our own in March of 2013. So that's
Awesome.
what got us on our path.
So you saw the value and the benefit and felt like you wanted to make an impact yourself?
Yeah, a lot of it was part of it was being gun shy from the previous experience and the internal medicine space. For that practice, I was doing home care, so I was for the first time having longer relationships with my patients because it wasn't the love them and leave them medicine of the ER, right? And you kind of go in, fix the problem, and then send them on their way. This was much different. I knew these patients a lot more intimately, so I would see them on a monthly basis, and so I really connected with patients in a different way than I had to that point. I really enjoyed that job, but when the practice got raided by the FBI and the OIG, and obviously things went upside down really quickly, and so that trepidation that I carried with me into the next job kind of kept me looking at things that I had never really paid attention to before, right? Making sure that all the billing was done right, and because now my name's associated with it, I don't want what happened before to happen again.
Mm.
And being to that point, and really, I guess through this point, being only formally trained as a clinician, my skill set really only allowed for familiarity with that one piece, right? But that also meant that I was very patient centered in my care, and the company that I was working for really wasn't built that way. It was built by somebody who's all business. They didn't know the medicine side, and not that you can't make that work, but it is harder, in my opinion.
Right.
So that's what we saw. We saw a great area where you could have positive impact. Night and day difference from the ER, right? Like in the ER, you're intervening in somebody's worst day and at least at recent past, right? But when you're doing testosterone replacement, you're helping people kind of evolve into the best version of themselves. And so seeing that transformation was really key for me. And that's what motivated me to want to do more. But for me, when I saw that business ethics were taking the front seat instead of medical ethics, that's when I knew I needed to create a path forward that didn't involve that balance, right? So really it's been kind of a journey into how you flip that. Business ethics obviously needs to be on the trip with you, but I think you can safely take a backseat to medical ethics and put the patient first and foremost as the goal of therapy rather than treating a bottom line. I'd rather treat a patient. So
Right.
that's what we did.
I know I've personally become conscious of my own low testosterone. Is this something that you dealt with personally? And is that what kind of, inspired and motivated you to keep
Yeah,
doing it?
I would say that's what ignited the passion part of it, right? It's one thing to watch somebody else, light up and do well, but when you see it and then experience it for yourself, you know that, it's something that you can then share with others. So, like I mentioned before, I was just kind of thrown into the mix. I had to do a lot of, or really all of kind of self-training when I got the job with the other firm.
Mhm.
And so they were just relying on the fact that, I had an active license and I would do what I needed to do to get better at my job. And I feel like I did that. But that said, it was, 3 solid months of reading through studies and scraps and books because there really, at that point, wasn't anything solid to stand on. The Endocrine Society had probably the best guidelines for testosterone replacement at the time, but they were very sparse and poor. It wasn't enough to flesh out a real treatment protocol that any of us felt comfortable with. So we were kind of piecemealing it a bit. And then so developing that out for them helped us solidify our own brand of care. And then I realized after diving into all of those pieces for the first few months, once I got my knowledge base to a point where I felt like I could then relax a little bit and just leave work at work, I realized that that extra time was keeping me hyper focused. And I then realized that I was having trouble with word finding and I was having trouble communicating. These were things that I felt were part and parcel to my character, or at least had been through that point. And so when I realized that I wasn't as articulate as I felt like I had been in the past, it was a huge blow to my ego. And I realized that, this is one of the symptoms that I'm talking to patients about. So I started kind of going down the list. I'm like, you know what? I am fatigued and that does get worse throughout the day. And
Right.
I'm not sleeping as soundly as I was. I'm waking up into the middle of the night. And that's not normal for me. Right. And then libido, when I had to, self-assess, I realized, yeah, it is decreased, but I hadn't noticed it because it was kind of backing out of the room slowly. So it wasn't something I was checking on a metric, scale every day. So when I realized that, for me, cognition was the big sentinel symptom, there were a lot of other things brewing that I just kind of let slide. So at that point, I was 35, and my testosterone levels at that time were in the low 200s. Normal is between 300 and 1,000. So it gives you an idea of kind of how far off the mark I was. In your 30s, you should be close to your peak. So I should have been closer to that 1,000 level. And so I started down that pathway. And for me, I've been able to see patients positively improve their lives through TRT, and I knew what I should feel. I knew a couple months into it, I wasn't feeling that. The numbers all looked good, but my personal response to it wasn't where I thought it should be. I realized that that was because my thyroid was not being treated in a way that I thought it should. Kind of after diving into things that have to do with the hypothalamic pituitary and hormonal organ axis. And so I had been diagnosed with low thyroid or hypothyroidism back in 2003, right as I was leaving the fire department and starting PA school,
Uh-huh.
and had been on therapy for that for a decade. And I realized at that point that to that year, nobody had ever asked me about my symptoms related to hypothyroidism. It had been diagnosed by a lab. My treatment and dosing had been decided upon by labs, and never once were they actually treating me and my symptoms, right? So I had to go back to the drawing board with my thyroid, fix that. And of course, that changed the way I approach hypothyroidism and thyroid care. Once that was set and then went back to TRT, then I was feeling everything I was supposed to feel on testosterone replacement the first time. So that process of trying testosterone replacement and then not seeing what I should, and then having to realize that thyroid maintenance or care or issues had a lot to do with the same symptoms that you see with low T, was a game changer for me. That's when I started to open my eyes to the fact that testosterone is kind of feathered in on a lot of other things in the wellness space, and we had to become good at things outside of just TRT.
Right. Oh, that's interesting. I hadn't thought about that. Um, Now, can you explain, is there a specific age or are there lifestyle things that people are doing that are leading to low T? Or, is there something that's causing it per se, or is this just, something that happens for people?
Well, a little bit of everything you mentioned there, but I'll tell you that the old school of thought was that this was all behavior led, right? So it was something that you could change by behavior modification. You shouldn't have low levels unless you're, in the rocking chair years.
Mhm,
What should happen? Testosterone should spike in college puberty, peak in your late 20s, and you should lose testosterone at a rate of about 1% of production per year after age 30.
hmm,
If you follow the math on that, and peaking is somewhere around 1,000, and then you only subtract 1% every year thereafter,
mhm,
you should have to live to be 121 before you get to below 300, before you get to low levels,
okay,
meaning that you really shouldn't ever be dealing with low testosterone levels, at least until your rocking chair years,
right,
right? The fact that we're seeing it in not just 70-year-olds, but 60, 50s, 40s, now all the way down to 20-year-olds
right,
and people in their 20s. This is an abnormality that can't be explained away by behavior. I have patients across the spectrum of body habitus, right? And we've got guys that are big and carry extra weight like I do. They've got guys that look like marathon runners. We've got guys that look like bodybuilders and everything in between. And they all have the same symptoms when their numbers are low.
hmm,
So the smartest minds in the field, in my opinion, are pointing toward endocrine system disruptors. Right. So endocrine disruptors are everywhere. A lot of these, most of these are man-made, chemical in nature, but they taint the environment in a way that's virtually inescapable. Right. Think about how ubiquitous plastic and plastics are in our environment. And if you can't get away from plastics, you can't get away from the chemicals and the particles that are changing the way that our body communicates with itself.
right,
And the hormonal system is nothing more than a chemically mediated communication system, right? So it's easy to throw that off kilter. So as your body sees things that it misinterprets, maybe as an estrogen or a testosterone or something of an androgen or an estrogen, it changes the reading of thermostat, if you will, right? If
uh-huh,
I have a thermostat, I'm trying to get my home to cool down to 70 degrees because it's 90 degrees outside, and it thinks it's 70, but it's only 84. I'm not going to get the internal temperature that I want because my thermostat's not reading correctly.
right,
Well, we have a thermostat, we have an air handler, and then we have a room temp, right? That's kind of tantamount to the hypothalamus, the pituitary gland, and in this case, the testes.
mhm,
So if they're not all communicating correctly, then we don't have proper production.
hmm,
That's broken down into two main categories. It's primary hypogonadism and secondary hypogonadism. And by and large, the most common thing that we see is the fact that all the pieces, the biological pieces are intact and doing something, but it's that communication pathway that is broken, right? It's not that the brain's not sending any signals, it's that it's sending wrong signals. So the testes are already behind the eight ball in production. So that affects, of course, not just testosterone or androgen production, but also fertility. And this is something we're seeing across all species, not just humans, right? You can see it in zoological research as well,
hmm,
where there are changes in the environment because of the failure of androgen production. And so unfortunately, this is reaching down into people in their 20s. We're very stringent about putting patients on therapy only after they've been proven to have low testosterone. We're not just doing it to run numbers up the flagpole. We're looking in a safe way. But even in that, we have many patients in their 20s that traditional thought would have said, I mean, there's no way that somebody who's in their late 20s should have low T. But when you actually do the history and you objectively look at their labs, it all matches up. And those guys do much better on therapy. So
hmm. So what I heard was that, that there was effectively toxins that
mhm.
are irritating things. So would is part of your treatment detoxifying people?
Well, unfortunately, there's not a good way to get away from that, right? And people are now starting to talk about PFA, that's the PFASs, the forever chemicals, and the other things are phthalates, and just again a multitude of chemicals, primarily driven from the plastics and petroleum industry that are in our environment that you can't escape.
Mhm,
So unless you can make your own dirt and live in a biosphere that allows you to only have, fresh air and fresh soil and fresh food and everything else comes with it. You can't remove that, the impact, right? So there's people have implicated lots of different things, and it's come up and down in debates and literature for that matter. Are phytoestrogens or plant-based estrogens a problem? Are the xenoestrogens, the chemicals that look like estrogen in your brain, a problem? Well, really, all of them are to some degree. But we don't have a hard and fast way to remove those influences from the body. So we still are just left with that broken thermostat, right? We just don't have a way to right the body's internal communication malfunction. So with replacement, there's buzzes around what renaming testosterone replacement to show that it's optimization. And the reason I still espouse the term testosterone replacement is because I am replacing what your body's not doing. I'm not trying to come along a broken system and prop it up on stilts. We're acknowledging that we have an environment that's working against us. And if we've already tried all those pieces of trying to detoxify where you can, improving the quality of your sleep, and improving exercise using high intensity interval training, maybe intermittent fasting, managing insulin levels, there's a host of things you can do. And I've walked patients through that process. But I've never seen a profound change in testosterone production once somebody shows low T, right? So if they're symptomatic and they've been that way for a while and they come to us, we actually end up treating roughly about 60% of the people that darken our doorstep. Therapy is not right for everybody, and not everybody who has the symptoms of low T actually has low T. But unfortunately, I don't have a good way to unpack the toxin part of it, right? But I can come in and fix, at least levels wise, by replacing what your body's not doing with therapy. So that's our focus.
Can you talk a little bit about the like the symptoms that say I would be looking for, and if I had these symptoms, then those would be more indicative of low T.
Sure. Yeah. Fatigue is probably the most common one. And I always like to characterize that because I think it's important as to what part of the day you're experiencing fatigue, and is it something that gets worse as the day goes on. When naturally produced, testosterone should be at its highest in the morning, fall throughout the day, kind of replenish overnight, and repeat the pattern, right? So if you feel decent in the morning, when your testosterone levels are hopefully at their best, but your energy levels and other things start to decline throughout the day, that's more the pattern that we're looking for. Usually kind of a global fatigue that worsens throughout the day. If you're only tired in the middle of the day, especially after you eat lunch, I'm going to be more concerned about your thyroid, for instance, right? So the timing and the overall pattern of your fatigue matters. Decreased libido is a big one, and again, this is something that, like for me, a lot of guys don't really notice it until somebody else notices it. Especially if you're thinking setting up a marriage, right? It busy, you got kids, you got a job, you got 1,000 things going on. Maybe it's not something that's as front burner of an issue for you if it's not hitting your brain, right? And so, I see a lot of guys come in whose wives or significant others have scheduled a visit because all of a sudden, they're not as interested anymore. And more often than not, the thought process behind that is, well, if he's not interested in me, it's because he just doesn't like me anymore, or he's being satisfied somewhere else. And those accusations fly, right? But I mean, those are things that we see commonly. So decrease in libido, which can also play into a change in erectile function, right? So erectile function, not just erectile dysfunction where you can't obtain an erection at all, but if erections are less frequent, not as strong, the duration isn't satisfactory for both partners, like all those things can hinge on testosterone levels as well. Other things that are sometimes counterintuitive to what the rest of the public thinks of when they think of testosterone. Most of the time they realize it's a steroid, so they think roid rage is a problem. But often irritability is a sign of low T, because even roid rage is more linked to high estrogen levels than it is high testosterone levels. Male body's not readily made to deal with high estrogen levels. For guys, most tests will have your normal upper limit of normal somewhere around 40 to 60, right? For women, their normal is around 400 at their peak, right? So our bodies are tuned quite differently when it comes to estrogen. But the fluctuations women see around PMS and especially mid-cycle with their estrogen peak around day 12 of their cycle, it's because of estrogen where they have most of their symptoms of irritability and bloating. We can have those same things as our testosterone levels fall. Typically, the estrogen levels don't fall commensurately, right? So if you have testosterone levels should be here and estrogen levels should be here, and your testosterone levels drop, you end up with estrogen dominance, meaning the estrogen level may be normal for you by the numbers, but it's now unopposed by the right amount of testosterone. So now you have estrogenic symptoms. You might be, again, more irritable. You might actually be a little bit more emotionally labile. You might be crying at Hallmark commercials and a little more sappy than you used to, right? It just depends on how your body responds to that excess estrogenic influence. Quality of sleep and mainly maintaining sleep is a big one. If your testosterone levels are low, it's usually more difficult to maintain sleep. Initiating sleep is not so much a testosterone issue. So again, it matters what kind of sleep disruption we're seeing. We see a lot of guys with low T and sleep apnea. So if you're not sleeping because you're not breathing, again, different problem, but sleep apnea can cause low testosterone as well. Other things we see would be changes in body composition, drop in muscle mass, increase in fat mass, difficulty losing weight, difficulty gaining muscle. And then for me, like I said, cognition was a big part of it. Just word finding, quickness of thought, like those things were huge for me. And that's just because that's what I was focused on, right? At the time, somebody sitting across from me for a consultation about testosterone replacement. And to that point, I'm probably the foremost expert they've ever talked to about testosterone replacement. And I'm forgetting words that I've, read 50 times in the last 2 months. It's not something that was normal with my thought processes, right? So that was my big red flag, was cognition. But yeah, so fatigue, decreased libido, changes in body composition, trouble maintaining sleep, and then cognition as well. Well, all those can be part of it.
When you first initiate, treatment with somebody, are you more conservative initially in trying to take, either perhaps supplements or types of food, or, are there recommendations that somebody who doesn't necessarily want to get on testosterone replacement right away, that maybe they can try and see if that works?
Absolutely. It's always part of the offering. And we tell everybody that, you have a multitude of options, including not starting therapy at all. Right. And so for those people, we kind of gauge it on each individual person's decision of which direction they want to go. A lot of that comes down to patient being honest with themselves about how they're going to be with compliance, right? So if they know they're not going to be a good patient in with regards to behavior modification, and they're not going to make sure that they're sleeping well, go get a sleep study, make sure they don't have sleep apnea, and then address that issue. Eat better. And perhaps, like it's mentioned, intermittent fasting is something that helps with insulin levels, and then also overall wellness, and it can improve testosterone production. Start working out or changing the workout to HIIT training as opposed to just running on treadmill for hours a week. There's lots of different things. Supplement wise, you can look at vitamin D levels, zinc, magnesium, and then there are other supplements out there that help your body improve the balance between total and free testosterone. We're in our practice, we're a big believer in the calculated free T test being a lot more specific and accurate when it comes to the assumption part behind the lab's piece of symptoms and management. So there are a lot of things that people can do to improve their current production, or at least their reaction to their current levels. But most of our guys, once they've come to us, they've been thinking about it for a while, and they're usually ready to do something a little bit more definitive. So most of our patients who choose therapy aren't starting with the behavior modification side. They want to start medication, but even in that, we are also very careful to start at a dose that we almost always are going to have to increase from, right? I'd rather start low and slow, using the lowest effective dose to reach an optimal response. And in that, we're also, choosing to limit side effects, and so that we can manage those along the way. The goal of therapy is to keep the burden of therapy as low as possible, so that we achieve, again, optimum with lowest effective dosing.
Mhm. If you're replacing what the body is supposed to be making, does that mean that once you start with the testosterone replacement, that effectively you would have to remain on it indefinitely?
Yes and no. So what I tell people in that is that you can stop testosterone replacement at any time. And let's say the term from you starting to the term of you choosing to stop is a matter of months to years, a few years, right? You can expect basically to return to your baseline within 2 to 3 months after stopping testosterone replacement.
Mhm.
Now, we've also drawn a line in the sand, right? If therapy was managed correctly, we've gone from terrible symptoms to optimal testosterone, and now your body knows the contrast. right? So now you've got to contend with not just how you felt at baseline, but knowing how good you can feel if everything's going right, right?
Mm-hmm.
But that doesn't mean that you stop producing altogether. I've never seen an instance of that. You'll hear a lot of that once you start, you can never stop. You can, but honestly, if everything's being done right and people were careful to think through their options before starting TRT, then most people aren't wanting to stop because they don't want to feel the way they did before therapy. So the only big downside there would be that, 2 to 3 month transition point where you stop therapy and you're going to feel worse than you did before you started,
Right.
because suppression of natural production means you're going to fall below your baseline or initial baseline before you bounce back to your baseline.
Right.
Now, if somebody's on therapy for 20 years, their baseline is going to look radically different too. Like I said, if we're supposed to lose 1% per year, but by the numbers, it looks instead we're losing 3 to 5% per year or sometimes more, then 10 years down the road, your baseline is going to make you feel pretty terrible compared to the baseline from 10 years prior. So,
Right. What would you say was what are the components of wellness that are closely related to testosterone?
the biggest pieces that we've seen that are necessary to look at, I've kind of already touched on one. Thyroid is huge. It's something that is largely overlooked, especially in men. So making sure that your thyroid is not giving you symptoms that are mimicking low T, and we're assuming that that's a bigger piece than it is without affecting change at the thyroid level is important. Sleep apnea, also kind of mentioned that too. We see a lot of guys with sleep apnea in concert with their low T. In fact, this is something we find because we're looking for side effects that are related to testosterone primarily. So we know that testosterone will make your body make more red blood cells and has an effect on a peptide hormone from your liver. And so it kind of deregulates iron absorption. So with more iron available, your marrow makes more red blood cells, and now your hematocrit can creep up. The thickness of your blood can creep up a little bit.
Mm-hmm.
But if you're normal before therapy and we start on therapy, that increase might be a point or two, right? So it's not going to take you from normal to high just by itself. But if you add to the mix sleep apnea, obstructive sleep apnea, and not necessarily to the point of having apneic episodes, but even just, sonorous snoring, that it's just less efficient breathing, your oxygen levels dip through that process. And so if you're going to bed every night and your oxygen levels are hitting low points, then your body's going to respond to that by trying to extract more oxygen from the environment. So it's going to make more red blood cells because red blood cells carry hemoglobin. Hemoglobin carries oxygen. So now we have a patient who already has a predisposition to making too many red blood cells because they're not breathing well or oxygenating well at night. And then you add testosterone to the mix that makes you make more red blood cells and makes you sleep more deeply. If you're sleeping more deeply, you're less likely to wake up from your snoring. And again, now you have kind of this hand in hand or hand in glove effect. So we can sometimes see sleep apnea worsen to a degree, but that's not something that is huge in and of itself. It's the fact that there's untreated sleep apnea. So that's another component to it. Beyond that, as we've been focusing more on wellness, just like everybody kind of has since COVID and the things that just kind of come to the forefront, gut health is hugely important. Making sure that that's all a piece of it. Of course, managing your weight is a big piece of it. Testosterone optimization can help you with those things, but you may need other help along the way. So the newer drugs like semaglutide or tirzepatide can help in those regards too. So these are therapies we offer as well, because overall that wellness piece has a lot to do with your activity levels, and your activity levels have a lot to do with your body composition and weight, and so all these pieces are thought of in conjunction with what we do with TRT.
How is it that you mentioned in increasing the exercise and doing more HIIT training, how does that affect the testosterone, and why would it increase?
So if you think about the types of workouts that, say, a sprinter does versus what a marathon runner does, and let's take testosterone replacement out of the picture, you can tell just by looking at the body of a champion marathon runner and the body of a champion sprinter that their bodies are tuned to do different things. And that's because they train in different ways, right? Essentially, to be able to be good at marathon running, your body has to do well with a limited amount of resources and a longer period of exertion. And so at some point, your body is cannibalizing itself to fuel past a certain point, right? You can only store so much glycogen. You can always only have so many calories in reserve. Whereas sprints are using the stores that are readily available and not really digging into breaking down muscle for fuel at the same clip as a marathon would, right? So HIIT training does more of the latter. It's going to help you in a condensed period of time deplete your body of those stores that it has prepared for exertion, and then allow time for rebound before you do that same workout again in intervals. But then you also take rest days in between so that we're inducing a catabolic state that will exist for the next 36 hours. An anabolic state that will exist for the next 36 hours versus the catabolic state that'll exist for the time well after training for a marathon, right?
Mhm.
So it's just a difference in the approach. And of course, inducing an anabolic state means promoting androgen synthesis. And so when you look at HIIT training by itself in the studies, it is the best type of exercise to promote testosterone replacement. Heavy exertion, usually large muscle movements, usually some resistance training in there. But again, even if you're just talking about sprinting, your body's going to respond much differently if you spend 45 minutes 3 times a week doing sprints at intervals versus using that same amount of time and giving it all you got on a treadmill where you're just burning past your stores
Right.
and through to the muscle and tissue that your body needs as well. So it's just the phase of recovery that we're leaving the body in. Is it anabolic or is it catabolic? And so HIIT training favors more of the anabolism after.
Can you just clarify for the audience what the difference between the anabolic and catabolic?
Basically mean a building state versus a breaking down state, right? So with HIIT training, you're breaking down the stores and then hoping the body rebounds with a better amount of storage so that it can then do more work. And that phase is the growth phase or building phase or anabolic phase.
Right.
If we're doing workouts that go past our stored energy and then has to break down our body, that's inducing catabolism or that breakdown process. And then our body stays in that breakdown process even through a lot of the recovery phase. So it's just coming to the line and then having the body rebound to a better spot versus going to the line, plowing past it, and then sending the body reeling into recovery rather than replenishment.
Women have issues with low T as well. Is that correct?
Absolutely. Yeah. We treat both men and women in our practice. We didn't at the beginning. Like I said, we were kind of writing the protocols as we went for men. So women are infinitely more complex when it comes to the hormone side of things. But yeah, we see women have all the same symptoms roughly, minus their erectile function. But still low libido, low energy, difficulty maintaining sleep, body composition issues. And so we treat the women also with injections, but about on average like 1/10 of the dosing. So it's just a different amount of medication, but the same type of treatment for women as well.
Do all the other hormones for women like that, the estrogen, and are you doing any type of replacement from that standpoint, or is it just the T?
No, yeah, it's the whole mix there, and so the thing that changes with women, is that estrogen progesterone piece, right?
Right.
So what I tell our female patients is that I consider the 4 pillars of hormonal health for women to be estrogen, progesterone, testosterone, and thyroid. So thyroid's still very important, testosterone still very important. But obviously, with progesterone and estrogen is something that's vitally important to the female cycle. And that, of course, changes over the course of their biology, whether they're menstruating or not, or premenopausal, postmenopausal. But ideally, we're looking to right a lot of those deficiencies that often get thrown to the wayside and have the band-aid of oral birth controls thrown at them. So typically, when a female patient goes to whether it's their primary care or gynecologist with hormonal issues, the answer is almost always a birth control that gives them a fake estrogen and a fake progesterone, as opposed to giving them back what their body is missing, which is the equivalent of naturally produced progesterone or estrogen. So progesterone deficiency, I think, is more common than anything else as far as the big miss there. So the estrogen, women's bodies are exquisitely good at creating estrogen up into their premenopausal states.
Mhm.
But progesterone deficiency is a very profound issue that I think is not looked at enough for women. And You see that in the literature when they talk about protecting pregnancies. That's changed in probably the last 10 to 15 years, where now women's progesterone levels are on the dashboard while they're pregnant. So they'll go on progesterone injections only while they're pregnant. And then, by and large, they act as if that progesterone deficiency just went away with pregnancy, which it doesn't. It's there all the time. And kind of like I was talking about earlier with testosterone falling and estrogen staying high, that same estrogenic influence or estrogen dominance pattern can exist when there's not enough progesterone.
Mhm.
So you look at the cycle changes, and if estrogen is left unchecked, think of it as a proliferative hormone. So it's ramping up production of uterine lining, getting ready for a pregnancy. If pregnancy doesn't occur, progesterone should come in and kind of right the ship and calm things down, keep it very orderly. And then the end of the cycle means PMS hits, and then the body flushes and gets ready for another one. But if progesterone isn't there to make that proliferation of the uterine lining stay in check, then it overgrows. And that's when you have a higher degree of dysfunctional uterine bleeding. So women are then having a heavier period. They're having more cramping to rid themselves of the excess that the body produced under a higher estrogenic influence. And then they can have more frequent periods because now the timing's off, because the building was off. So all those pieces kind of, again, layer into one another.
What are the options for testing and measuring the hormones and the testosterone?
We still use serum as our go-to. There are other options like saliva, and there are finger prick tests and those. Honestly, I've just not done enough work with those to compare and contrast how that compares to serum. A firm believer in a good serum study done for men. It should be done in the morning in a fasting state before 10 a.m. That gives their body the best chance to get their highest level. So we're looking at the peak of the day, and if you're low at your peak, we know you're low all the time, and we check twice before we confirm that diagnosis. For female patients, same thing applies with the testosterone side. But if I'm also looking at progesterone and estrogen, I want to look at a specific window in their cycle. So if they're menstruating and they have a kind of a textbook 28-day cycle, I'm going to look at when that progesterone peak should happen. So that'd be in a window of, say, days 18 to 22 for their progesterone peak. And that helps me discern whether or not we're looking at a true deficiency on the progesterone side. And the same thing, we confirm that before we have the next steps about talking about therapy options.
Once you identify, what the problem is, or, the level, how do you like, what's the I know there's a couple different ways and methods to give the hormones. What's your preferred method, and what's the reasons why for each?
Yeah, so for testosterone, there are three basic modalities. There's topicals, pellets, and then injections.
Mhm.
So topicals with creams, gels, and patches. Pellets are implanted under the skin and should last months, depending on how much you use and whether it's being used in men or women. And then injections, which are typically done weekly or maybe split up more frequently than that. Some people even do micro injections every day. I favor injections. I have all three modalities available to me. I use weekly injections. So at risk of sounding like the hair club for men guy from the 80s, I'm the president of the Franks, but I'm also a patient. I use weekly injections. I find it to be the easiest for compliance. I think once you start injecting multiple times a week, it's just easier to forget, and it's easier to push off, and your cycling gets off.
Mhm.
Many of our patients do like having a little bit more of an even keel and less of a peak and trough. So they'll usually kind of bisect the week and do like 3.5 days, Monday morning, Thursday evening kind of thing. And I have a handful of guys that, they want to drill it all the way down to the absolute lowest effective dose, and they'll do a subcutaneous injection every night.
Hmm.
I'm just not willing to do that. So I don't recommend it from a compliance standpoint.
Right.
Pellets, we offer them. I don't love them. It's good for people who travel a lot and they don't want to be, toting their medication around or that sort of thing. But it's a minor surgical procedure. I'm burrowing holes in the fat pads between your skin and your muscle to lay down pellets, and then extrusion is a problem. Infection's a higher risk because using a trocar to disrupt the skin every 5 to 6 months.
Mhm.
All right, so it's not something that is as clean and easy as an injection, but it is less frequent. Topicals, especially on the male side, again, studies will tell you that up to 40% of people don't absorb enough to make a difference, right? So if you're not an absorber, then it's just off the table. For the remaining 60%, you're back to the daily use thing, right? And if you don't slather it on at the right time. If you put your shirt on too soon, it ends up your shirt not on your skin. If you sweat too heavily, it comes off. If you shower too soon, it comes off. It can come off on people who don't need extra testosterone, like your toddlers or infants, right? I don't worry so much about transfer from adult to adult, even a male to a female, but to a little kid, it could be a big problem. So for those reasons, I prefer injections. When it comes to women, I still prefer injections. Not a lot of people use injections for women, but again, you can push out the frequency, you can drop the dose considerably, which we do with that. But then when it comes to estrogen and progesterone, I typically prefer orals for progesterone, and I do prefer strongly a bioidentical progesterone, so a compounded version, not just the Provera or the commercially available really non-estrogens or non-progesterones. They're chemical versions of. And then for the estrogen side, I usually do topicals for that. That's something that for our female patients is usually well tolerated and well absorbed for estradiol. So it's a little bit different for the hormone that we're selecting. When it comes to thyroid, I prefer naturally desiccated thyroid products. So instead of the conventional Synthroid or Cytomel, most people are treated with just Synthroid. Synthroid is a synthetic version of T4, but the more impactful hormone is T3, and Synthroid doesn't have any of it in it.
Mm-hmm.
I use Armour Thyroid as my go-to, and it has a mix of T3 and T4 together. And so I'm focusing more on, of course, symptoms and free T3 levels, and I use a medication that has T3 in it.
Okay. So with the injections, then, is that something, if they're going to be giving them, getting injections often, is that something that the patient does to themselves, or are you?
We have both options available. So we offer in-clinic care, and then we offer telemedicine, so they can do care at home, and they meet virtually just like this with one of our providers on a monthly basis, and we walk through all their questions. We still do labs at the same intervals. But yeah, we go through all the coaching of, this is how you drop your medication, this is where you need to inject, and we can usually do training in-house if they're, close to any of our brick and mortars. It's some of that becomes a little more challenging now that we're offering telemedicine across the state. But it's something that we, the whole world was forced into in 2020. So, we've got a few years of practice under our belt there.
Yeah, it seems like with the hormone replacement that it would work fairly well with telemedicine. I mean, I obviously assuming the person feels comfortable giving themselves injections.
Yeah. And on the other side of things, like I said, I'm a patient myself, and I have been injecting for 10 years, and I hesitate every single time I go to inject myself. It's just it's just self-preservation, right? So it's not that you ever get to a point where you probably love it, which again is why I choose to only do it once a week and not more frequently.
Right.
And there are ways to do, like I said, subcutaneous. If you're using the commercially available testosterone from your typical Walgreens CVS place, I would not recommend doing that subcutaneously. That's something that really should go into the muscle, because that's the way that carrier oil was made to be administered. But some of the compounded versions are often done in grapeseed oil, and that's better tolerated in the subcutaneous space. So for our sub-Q injectors, we usually have them on compounded testosterone.
Hmm. So did you say that they have testosterone generic stuff at Walmart?
Yeah, well, I mean, yeah. So the Walmart pharmacies, meaning, yeah.
Okay.
So Walgreens, Walmart, but so there's generic testosterone everywhere. But for the commercially available types, that's all in cottonseed oil. So again, you just have to be careful as to what modality you're using, where you're getting the source, and then how it's administered at the patient level too.
So just to clarify, you said the cottonseed oil is no good and the grapeseed oil is the better. Is that correct?
Well, they're both good for delivery of testosterone, but when it comes to whether you're giving the injection of the muscle versus subcutaneous plain, that's what matters. So if you're going subcutaneous, I recommend a grapeseed oil-based testosterone.
Yeah.
If you're going muscle, you can do either one.
Are there any things that you would avoid, or, things that people need to be concerned about if they go to see a provider? Are there any red flags that people need to look for?
Not really, no. So the only big things, well, I mean, there are big things. So if you are a person with a family history of prostate cancer, then you need to be careful monitoring that. Now, that should be done on our side too, right? Now, I have those conversations, and I tell those patients to let their primary care doctors know that even if they do or don't like testosterone, you need to disclose it to them, because it doesn't hurt to have a couple eyes on something that could be serious. That's one of the few contraindications to testosterone. That would be an active prostate cancer, or a untreated CHF, fulminant CHF, congestive heart failure. But for the prostate side, it used to be thought for decades that testosterone caused prostate cancer. We now know that to not be the case. Years of studies have shown that, but there's a correlation. So some prostate cancers like testosterone, so they'll grow more aggressively in the face of TRT. So we're going to know that usually very early on if you're, number one, a patient who's predisposed to that because of your history or behavior, mainly smoking, then we're on the lookout even more carefully than we are for everybody else. But when we look at your PSA levels usually every 6 months or so, and track that over time. So your prostate specific antigen is a blood test that was made to look for prostate cancer, but it moves most likely with prostate change. That's like infection, inflammation, growth of the prostate. That's non-cancerous. And if somebody were to have a dormant prostate cancer that's not growing because they don't have testosterone, but it thrives in presence of testosterone, that PSA would pop in the first few months. So we're going to see it on early retests. That's happened a very small handful of times in 12 years of doing this. So it can happen. But in those cases, again, testosterone isn't causing prostate cancer. In fact, we've had a few patients who have developed prostate cancer while on therapy. And typically we catch that earlier because the tests are being done more frequently. They're usually not even symptomatic by the time we identify it. And for all those patients, their outcomes have been positive. So caught it early, treated it early. They stayed off testosterone for a while. We've had at least 2 of those guys come back with clearance from their urologist post, once they're cancer free, their prostate cancer has been mitigated.
Huh. So, okay, so the testosterone, there's cancerous tumors in the prostate that feed on the testosterone?
Right. Yeah, that's not all prostate cancers. Yeah, but some are androgen sensitive.
Huh, okay. So that's why you test on a regular basis to just ensure and just make sure that the PSA is not going up.
Yeah, and then we're also looking at symptoms in an umbrella of symptoms called LUTs or lower urinary tract symptoms. So things that basically indicate that it's harder for you to move urine out of your bladder because of an enlarged prostate. Those are things that we check off as well.
What are the things that you would consider that are important for better health and to live longer? When I with this podcast, I talk about like becoming superhuman and being able to do things that perhaps other people aren't able to do, or do things at a higher level. How do you feel like this is like what you're doing is helping people to achieve their best version?
Yeah, so I was thinking about this when I saw the title of your podcast and did some digging on it, and then so with testosterone replacement and the way that we manage it, the way that it would support doing things that somebody else couldn't is not starting from a dug hole, right? So optimizing testosterone replacement should be about bringing you a little bit back to a little bit better than the starting point that you expect to be at, if that makes any sense. So in other words, like we talked about, there's this normal range. It should spike and cause puberty, peak in your late 20s, and then you start losing some production throughout your 30s and beyond.
Mhm.
But if instead we're targeting optimization throughout the entirety of your life from the time you start therapy, then we can essentially live in that optimal stage of where we should have been in our late 20s, well past our late 20s, right?
Right.
So not only are we raising it up from the well that you're down in when you have low T, we're not just getting back to the surface. We're creating a platform from which then you can expand to and achieve some of those other things, right? So when you hypercharge the system to be able to build muscle faster and maintain it better, obviously physical deficits that you might have had when you had low T become a thing of the past, and then you can start building into things that are perhaps in that superhuman realm, right? Now, that said, there are ways to throttle testosterone use and achieve things that are not the norm, without necessarily reaching up to what bodybuilders do, which can often be abusive to the system. There's a place in between there, between normal testosterone levels and abusive super physiologic levels that still help us achieve greater things. I can think of a couple guys that I work with who they wouldn't call themselves bodybuilders, but most people see them walk around in a tank top probably would. But they focus more on agility and they can do things on the gym apparatus that look unreal, right? But it's because of what they're putting into their workouts, and they're able to maintain that into ages that are not intuitive for being able to move the way they move, partially because of TRT, right? Because of the fact that they can work out more efficiently. They have a more dynamic workout to begin with. The recovery phase is shorter and more efficient, so they're getting back to good sooner to be able to compound on top of that.
Mm-hmm.
For me personally, I could tell you that from the cognitive side, if I were still dealing with the brain fog that I was dealing with at 35 when I had low T, I couldn't do what I do now, right? So trying to move out of not necessarily out of, but from the clinical mindset into a business leadership mindset, there was a lot of work to be done there because it's not something we learn in school, right? And I'm sure, as you know, when you practice doing what you do, that there's a market change for most people when you're only steeped in medicine to think differently in the way that you need to do to run a successful business. And that takes a lot of concentration and intuition, and that's almost impossible to achieve if you are fighting through brain fog just to get through your normal daily tasks, right? So hormonal wellness, from all those pieces, from testosterone to thyroid to managing cortisol, managing stress, I think of it kind of like as Maslow's hierarchy of need, right?
Mm-hmm.
And in that, I would say hormonal wellness is closer to the tip of that pyramid, right? It's not all the way up to self-actualization, but it's not, it's more important than, or not necessarily more important than, but it's a couple of rungs above just mere survival, right? Achieving hormonal wellness impacts every role we play. So whether you're talking about as a business owner, a husband, a father, a friend, a son, like all of those roles are impacted by our hormonal wellness. So if our hormonal wellness is optimized, we can be optimized in all those roles too.
So what I'm hearing is that you basically, when you have low T, you're kind of, as you say, you're kind of starting in a hole.
Correct.
And so you kind of have, like a deficit, or maybe when, if other people are at a normal level, you're at a disadvantage effectively. Is that what you're saying? So
Absolutely.
kind of getting back to that baseline and
Yeah,
allow you to be
that's
your best
that's
version.
kind of where we start. Yeah, I'll tell people often, and sometimes it's hard to convey something in a quick little package, but I tell them it's about getting back to good, right? And it's not necessarily about making monsters that are gonna grace the stage at a bodybuilding competition, but your body composition is gonna be a lot better and easier to maintain when your testosterone is optimized, right? And so again, we're pushing toward not just normalizing, but optimizing in a safe manner, right? So that we don't have to worry about cycling on and off like somebody does when they're abusing their body. Right? We're looking to ride that crest of the wave in perpetuity. Right?
No, that definitely makes sense. I mean, I could imagine you'd feel superhuman if you had felt like crap and fatigue for a long time, right?
Yeah, again, and that's the thing, the bell that's rung when you give somebody that contrast. We don't have a lot of guys saying, I feel great, but I think I'm going to stop. And, unless, there's, cost things involved and that sort of thing, but that's not usually what we see.
Well, I really appreciate your time, Augie. A wealth of information here. I definitely learned a lot myself. Very interesting. Viewers and listeners will get a lot of value out of this as well. So thank you again so much.
Of course, thanks for having me.
We appreciate you.
Yep.
Gandhi said, "Be the change you wish to see in the world. You must choose to become superhuman." Thank you for listening to this episode of the Becoming Superhuman podcast. I'm your host, Trevor Schmidt. Be sure to follow our social media channels. We'll see you next time.